So my name is Jacinda Van Hodson. I'm with Wave Life Sciences, and I'll make sure you hear me. And on behalf of David Spots, who is the commercial lead for our 2 investigational compounds, myself, and the folks back in Cambridge at Wave, we really want to thank HSC and you very much for giving us the opportunity to share a little bit about ourselves and also about what we're doing in HD. So what we're going to do during this portion of the program, I'm going to share a little bit about WAVE, what we stand for, our scientific approach and focus, but then also what really drives our passion for innovation and the science that we're conducting. Then the opening act, Dr. Guttman, will come up and he'll share information about those 2 investigational drugs, WAVE 120-101 and WAVE 120-102. He'll share a little bit of information about those 2 investigational drugs, as well as then provide you information about Precision HD1 and 2. Those are the 2 clinical trials that we'll be conducting. Oh, and then lastly, David, Dr. Guttman, and myself will be up here to answer any questions after the presentation. So does that sound good? Yes. All right. And I'm going to read every single word. But you know, this slide is actually really important, and you will see a lot of the pharmaceutical and biotech companies sharing these slides, this type of a slide. And what it means at the end of the day is that my role up here, our role up here, is to provide you with information that can make you feel more educated, more empowered to have conversations either with your healthcare provider or with your family members. The information that we provide is not meant to provide any sort of promise about how these investigational drugs will work. They have to go through the trials, then they also have to be reviewed by the health authorities as well before they're approved. So we always want to make sure that we're doing right by you and right by the community. So that's why you'll see these crazy slides. And if you have any questions that really are more focused around medical advice, please be sure to talk to your healthcare provider. Because as you can tell, I'm not a doctor, and I didn't have like a really good enough breakfast to even act like a doctor today. All right, so who is Wave? Wave is a genetic medicines company. And our focus is on developing cutting-edge technology and chemistry that will target and potentially treat the underlying cause of serious genetic medical conditions such as Duchenne's muscular dystrophy, ALS, and Huntington's disease. You've heard over the past couple of days a lot around about the ASOs. These are genetic medicines. And what we're trying to do with these, what we hope are potentially useful medicines for HD, is to figure out ways in which we can hopefully make them work better. So using something called stereochemistry, I am not going to go into that because it's almost like rocket science, but it's really cool chemistry to try and figure out ways in which we can hopefully make this type of genetic medicine work even better. And then we are targeting HD at the genetic level. So has everyone over, I just want to see how many people either went to Jeff's and Tamara's presentation yesterday where they talked about the ASOs? Okay, they really are neat, aren't they? They're really neat. They are, well, first let's start off. ASOs are also called oligonucleotides, and I really wanted to say that because it took me 5 months to learn how to pronounce that correctly. So they're known as oligonucleotides, antisense oligonucleotides, that's the ASO part that you hear about, oligos, ASOs. And these are short stretches of DNA and RNA that are custom built by these companies to fit here. So here you go from your DNA to your, this should say RNA, RNA to the protein. They are built to fit right here with the RNA so that when the cell sees kind of like this foreign matter, it's like, whoa, we got to do something about this, destroy it. And the hope is that it will not produce a mutant protein such as the Huntington's disease protein. So that's what an ASOS is. And I took that from you because you did such a great job yesterday defining it. Now, at WAVE, as I shared earlier, ASOS are what we feel and what a lot of companies feel. So you heard during the keynote yesterday, Roche is also looking at ASOS. We're also looking at ASOS. And what WAVE is trying to do with the ASOS is to create a new class of ASOS. And I'd rather say oligonucleotides. And our hope is by creating this new class is that hopefully, potentially, it may perform better, maybe it'll last longer, maybe it'll be potent, but those are things that we have to see in the research. But that is where our science is really focused on. So what's really driving our push for innovation and following the science? One is that we're a bunch of geeky nerds back at WAVE, and we're very proud of that. But what's more important is the reason why we come to meetings like this is so that we can sit down and have conversations about what is important to you. Your voice is what runs through our science. It's what really keeps us up at night to make sure that we are doing what is needed that's really going to help transform and have an impact on the lives of people living with Huntington's disease. So I want to say also thank you on behalf of David and I. Over the past day and a half, several of you have shared your stories with us, and I just want to give you a very sincere and heartfelt and emotional thank you for that. And also let you know that what you shared will be, not your names, but will be shared back at home office with our scientists, because there are some questions you have and we want to see what we can do to address some of those. So that's a heartfelt thank you. So that innovation, the passion for the science, the passion for the community has led us to 2 investigational ASOs in our pipeline, which Dr. Guttman will share. So we have 2 investigational ASOs. They target, you heard about SNPs. They target SNP1, SNP2. These are what we call allele-specific drugs. And we are also, one thing I did want to share, we are exploring additional SNPs as well. So I want to thank you for letting me be the opening act for Dr. Guttman. I'm sorry I didn't do the dance you asked, but I couldn't learn fast enough. But one thing I do want to share before I sit down, the photos that you saw, the images that you saw, are photos of folks and families who are actually living with HD. They wanted to share what their hopes and their aspirations are. And they asked that we do share. So this one photo is of a young lady whose aunt is living with Huntington's, and this is her hope, this is her dream. And this is something that pretty much stays on my refrigerator and makes me want to work even harder. And also just being here, I got to tell you, has been so fantastic. So with that, thank you. And I'm going to introduce, I feel like this should be a drum roll. Y'all can do it, our tambourine.
Hi, everybody.
Hello.
So this is a really exciting meeting, and it's a lot of work to be here, right? Are you guys exhausted, or are you? So, it's fascinating as an educator and giving talks to audiences like this, watching other people give talks. So the 2 keynote speakers were fantastic. Yesterday morning and this morning, the non-science keynote speakers, because they, as scientists, or clinicians, we're so focused on our slides and showing this or that, and they're wandering the audience, they're coming playing piano. I don't play piano, sorry. But they have an approach, and one of the things I was concerned about was that you've heard this stuff already 3 times, but what the two presenters did yesterday and today were that they repeated key messages. And I think that's what we're doing today. So I apologize if you've heard some of this stuff before, but I'm hoping I can reinforce what's being said. So that's important. So I'm in Toronto. We have a place called the Centre for Movement Disorders, and traditionally I've been dealing with Parkinson's disease and Huntington's, but over the last year or two, we've shifted our key focus on Huntington's because I tell patients I'm the most excited about what's going on in Huntington's. Parkinson's is a much bigger problem in our community. There's lots more people with Parkinson's, but you may not be aware that Huntington's, we're so much closer to finding really something that's going to make a difference. And I wanted to spend certainly this part of my career trying to make a big difference in this puzzle that we're trying to solve with Huntington's. And I think we have lots of the nuts and bolts of making this happen to move things forward in a different way. We actually share a space with an Alzheimer's research group, and Huntington's is so much further ahead than Alzheimer's, Parkinson's, multiple sclerosis, because everybody with Huntington's has the same problem. The gene defect mutation is so important and central to the role, and we can get at that central aspect. And that's the message that was given by the other speakers and will be the message from today. So you've heard about some of the studies so far, and there is an interest in doing what Tam presented to try and get at the mutant Huntington's protein. And the Roche way of doing this, which is based on very good science and looking at targeting the Huntington's abnormalities, and their approach is slightly different, and we'll focus on what's happening in this particular study by selecting only the mutant Huntington protein as what we're trying to go after. So you've heard some of this already, but we know that everybody has DNA, and everybody actually has two copies of DNA, one from your mom and one from your dad, and Tam had a nice little poster, or a little board there that she wrote on. And so we have the normal DNA, and that gets copied by RNA. That goes to a place called the ribosome, and the cell makes protein. So you've heard that before. And the protein, this is the stylized version. Ray had this really neat 3D model. I guess you guys have a 3D printer in the lab. I've never seen one of those, but it's pretty cool. So who colored it?
You did.
Yeah. So Ray probably took a magic marker and
Ray,
colored.
he's spray painted. He's obsessed with 3D printing.
Okay. So we know that this is what a normal DNA stylized looks like, but if you have a problem, something's gone wrong in the DNA, that's called a mutation. And so if that is not quite right, then that gets translated by this RNA, and then ultimately the product of the RNA, the protein that's formed in the ribosomes, is wrong. So we've seen in the presentation before lunch that the blob that looked like the Huntington is different, and it was interesting, it looked like the aperture of the hole there is different, and so things go wrong because the structure of the protein is different, and how the protein looks to the cell is different. So the mutant Huntington protein, we think, is the bad actor, the toxic chemical in the cells that for some reason picks out these nerve cells, even though it's in every cell of the body, and causes damage. So we think that this is the bad actor, and we want to get rid of this. So everybody has two copies, as I mentioned, of their gene. And so as Jeff said a couple days, or yesterday, you don't want to say one's normal and one's not, but so we call it the wild type. So that's the normal one. And people can have the abnormal one or mutant one, and that causes the protein. So in a dominantly inherited condition, you just need one copy of the bad stuff, mutation, to get the disorder. So this bad stuff takes over and overcrowds the good stuff. That's what happens in a dominantly inherited condition. Some people actually have two bad copies, so there can be what's called a homozygous possibility. If both of your parents have the bad gene, and you're unlucky enough to get both of them. But it's interesting, the clinical presentations aren't any different if you have one copy that's good or two copies that are bad. And that's an interesting political thing we won't get into. So we know that this bad protein exists, and we want to be able to target that bad part of the genetic information. So how do you do that? Well, you could try and capture the CAG repeat part, but that's a bit hard to do because everybody has some CAG repeats, and if you targeted that, you might get some of the cells or some aspects that are happening and you want that or are good for you. So if this is where the CAG part of the gene is, we want to go downstream and find something that sticks up and identifies, okay, this is here, but it's on the same part of the gene, and it gives us a marker. When I talk to patients, I actually say it's like a Velcro, so for the drug to stick on. So we want something to identify that this is the allele that they want to approach. And Tam did a great job yesterday talking about what the SNP is, a single nucleotide polymorphism that is slightly different than what other people might have. It doesn't have an impact on the function of the gene, and it's just a little bit off, and it doesn't make a big difference to the function of the gene. So we have lots of these things around, these single nucleotide polymorphisms, and when Wave started to look at this, and others did as well, we tried to say, okay, what were the things that were there in people that are highly prevalent? How, most commonly associated downstream for where the CAG repeat problem is. And they found two. One they just called SNP1 and another called SNP2. They're different. And we know that some people have SNP1, and some people have SNP2, and some people have both, and some people don't have it at all. So in this precision medicine part, where we're looking at your genetic information, and we're having information that is applied to you, the way that the study is set up in these molecules are that they will only work, as Ray Truman mentioned earlier, if you have either the SNP1 or SNP2. If you don't have these sticking points to the Velcro pads there, the drug is just not going to attach and not do its job. So if you have these SNPs, I've sort of gone over a lot of this, just a normal variation in the DNA, it doesn't impact on our health, it's a pin or a Velcro sticker, and these are found just by chance in different populations. Now, these populations were largely based on European descent individuals. So if we're doing this study in China or in some other places, we don't really know what the frequency is. And I can tell you that it's interesting, this is still early days, but looking at patients from our place and getting these SNP analysis, for some reason, there's about 3/4 of people that qualify for the study that have SNP2, and about 1/4 that have SNP1. We know that in other locations in the study, it's the opposite. 3/4 have SNP1 and 1/4 have SNP2. So there's just going to be different regions that have more of this stuff, and some of our patients have it. So, in summary, part of the normal genetics that we experience and have from our parents, we have 2 copies of this Huntington's gene. Genetic mutation is just in one for the vast majority of people. I've never seen anybody with 2 copies of the bad gene, homozygous, that others have. In the Venezuela population, for instance, where the gene was first discovered, there were homozygous individuals that were studied. The healthy Huntington's protein is important for brain function. We've heard that. Dr. Truant has been very vocal about that. We don't know exactly what part of our, from the time that embryological formation to early childhood, late childhood, and adulthood, the Huntington protein probably does different things at different parts of our development, but we think that we need to have normal Huntingtons around for brain function. And the beautiful slides that Tam showed just before, we think that it's got something to do for scaffolding, for holding together other things that are important for the cell, and probably DNA repair is an important part. And this is all being discovered recently. We've known about the gene since '93, and this is all hot off the press in the last 2 years. So the new approach is to tackle this in a very specific way, just to take down the mutant protein. So, 2 studies that we're doing, and they're really identical design, but if you have SNP1, you're in precision HD1. If you have SNP2, you're in precision HD2. And these studies have been going on for a while now. We started last year around this time. First patients were dosed in November of last year, so we've had almost a year worth of experience with that. And the most important message is things are going well, and there's no safety issues. So that's really key. And as you've been told over and over again, a phase 1 study, this is called 1B/2A. So typically in a phase 1 study, we take healthy controls. So these are the studies that you see students lining up because they get paid to participate, and they take a drug and they see if they have any side effects. That's, if you're taking the next blood pressure medication, that's what they do. Whereas it's not considered something that we want to do with an invasive testing as part of the clinical trial to do 7 lumbar punctures in a normal individual. They wouldn't like that very much. So we're going directly into 1B/2A, which means that we're doing a few other things. We're going directly to the patient population. And we're also looking at some indicators of what we call target engagement, or is there an outcome that could be an indicator for future studies. So again, this is the first part in the Roche program. They've already been through that with Islanders. They finished that. They said it's all done, safe, no problems. They're going to phase 3. This has to be done in this kind of drug before we can go to phase 3. So this is the early part. So we know that this very pure ASO, antisense oligonucleotide, I've been saying it longer than you, so. And we know that in animal studies, it can show a knockdown when we say knockdown, a reduction is really low. So Wade was very lucky that we've heard from Blair this morning, or yesterday, sorry, that there was 10 years of science that went into all sorts of stuff to say this concept works. Well, Wade was very lucky because that work was done, and they basically said, we have a different approach, and boom, we're allowed to go into people. And the regulatory authorities are very, they want to protect patient safety, but in a month, the Canadian government decided that's fine. We have enough information to say it's safe, and certainly our ethics review boards didn't have any trouble with this concept. So there are these 2 studies, again, very early. It's global. It's going on in many different countries. Can I say which countries?
Quick process.
Yeah, it's listed anyway. So it's going on in the UK. It's going on in the US. Canada was the first site. There is a site that's active in Montreal, and it's going on in Poland as well. I think those are the sites that are currently going on. There are other international sites that may have. So in each of the 2 studies, it's very similar to what Blair had presented, about 50 in each study, so in total 100. And we have this here. And this is a bit, also there's a placebo group, So it gets a little bit more complicated than the 1 to 3 ratio. So if somebody comes in and they're one of the first 2 patients receiving a certain dose, they have a 50-50 chance of getting a placebo versus the active medication, but the others have a 25% chance of getting a placebo. So that's what this is here. And they're administered by lumbar puncture. So we're looking at safety, safety, safety. That's the most important thing. And we're looking also at, how long is the drug in the system, both in the blood and the spinal fluid. What effects does that have? We're looking at MRIs and also the clinical rating scales that we heard earlier. So, lumbar punctures. Let's just take a brief sort of side step. Anybody here had a lumbar puncture? Yay, good for them. So in these studies, people have to have 7 lumbar punctures over the course of this study. So that's a big deal, but most of the time lumbar punctures go well. You've heard from the Roche people and from Blair. In their study, they're going to have 24 lumbar punctures over 2 years. So this is something that we got to get used to, thinking about what's involved in a lumbar puncture. I have a patient who was part of another study, an individual who had a lumbar puncture. It went very well, and I asked the question, asked her permission to say this, how was it? And she said, that was better than a bikini wax. So my response was, I've not experienced a bikini wax. But there you go. We had one young woman who blogged about her lumbar punctures and had it, have pictures. We've had other people allow me to videotape it for teaching sessions. I have a teaching session, a lumbar puncture workshop next week at the Huntington Study Group, the 3rd one that I'm doing, because we need to teach our colleagues around the world. Blair is an expert, certainly Ed Wild is an expert at this, but I think between those groups and the ones that were in the original study with Ionis, there's not a lot of expertise around. So what happens is that people either can sit up or lie down, curl up in a ball. We try to feel the right spot to go in. We've actually explored something that's a little bit different, which is using an ultrasound machine. So I have an ultrasound machine now, and I can find the right spot based on knowing the anatomy, and I can find out how deep I need to go from using the ultrasound. Because some people, we put the needle in, and boom, we're there in a much shallower depth, and then others that we have to go much deeper. So the needle is actually 9 centimeters long. We usually don't show it to people because it scares the crap out of them. And some people ask if their partner can be in the room. We want to make sure they're sitting down because one guy said, anyway, it can be very helpful doing the ultrasound. So in the last week, I've done 7 of them, and it went really smoothly. So we're taking fluid out for this, and we're putting fluid in. And it can take as short a time as 20 to 30 minutes. And sometimes, we have to do other stuff, and then it doesn't go as smoothly. In this study, and I think in Blair's study, I don't think there was a failure to give drug in any patient at any time. So that's good. So it sounds like a big deal. It is a big deal. There is a risk after having a lumbar puncture of having headaches afterwards. And there are headaches that are headaches, aren't a big deal. There are headaches that are a big deal. So there's something called a post-dural puncture headache, where there's actually too low pressure around the brain, and the brain causes pain. So the way to deal with that is to get people to lie down. They have to lie down and stay down. We've had some challenges that we say, okay, you gotta lie down, and they don't actually lie down. And so in the HD Clarity study, so if you remember from the last meeting in Halifax, when Ed Wild came in on his hoverboard and talked about HD Clarity, we've had about 8 people having post-lumbar puncture headaches on that, and one person actually went on to have a spinal patch to try that study, we're using a different size needle, a bigger needle, which is easier for us as neurologists to use. But in this one, it's a smaller needle, a 24 gauge needle, and we haven't had any post-lumbar puncture headaches at our site. I'm not aware of any site so far, and I think from what I've read about in the my study, there were a few, but they all resolved, and they're accepting that as well. So far, so good. There hasn't been any bad things happen. Certainly, there is a risk of other things happening, including bleeding from the area or infection, but that has not happened because people are being very careful about it. Okay, so in this study, people have to be between 25 and 65. So this has been one of the challenges that we have. We're told we have to follow the protocol. There's no exclusions from the protocol. But I have lots of patients that are over 65 who would love to participate in this, but fill out the criteria. We're trying to have a homogeneous group of patients, like we heard from the lower studies. We get this pre-screening blood test that I'll explain a bit more to see if they have the SNP1 and SNP2. And then we have to make sure that they have motor symptoms of Huntington's. That's to be exactly equal across all sites. So, we can get into a whole discussion about when does Huntington start, when is it diagnosed, but for the purpose of this study and the other studies that you've heard about, people have to have motor symptoms. And these are patients in the early to early moderate stages, stage 1 or 2. So what does that mean? People may not be working, but they're able to be pretty independent with their day-to-day activities and not require a lot of help. So it's similar. With the intrathecal administration, we give the medication directly into the space. It goes and can be transferred around the brain. People are asked to walk for half an hour after the administration of the medication in a similar way you heard from the Role studies. So we couldn't just give this intravenously. We couldn't give this as a pill because the medication would be destroyed by our body before it got to where it needs to go. So first step is to determine if, by blood test, if you have the SNP1 or SNP2. So it goes through a complicated process that you have the blood test. First of all, we want to make sure that you have the CAG repeat length that's appropriate. So at least in our patient population, most people know what their CAG repeat is, or at least they've had the test. We know that in Canada there was a period between about 93 and 97 or so that people didn't get their CAG repeat lengths, but we don't have to have that exact number for this study at least to go forward because it's actually done within the screening. So if somebody has the CAG repeat, that's okay. Heterogeneity means you have one copy of the gene that's abnormal. If you had 2 copies of the bad Huntington's gene, that would be being homozygous. It wouldn't be part of this because we want to selectively pick out one copy of that gene. So then it goes on to say, do you have SNP1 or SNP2 or both? So that's good. If you don't have it, that's a problem. You can't come into the study. And then finally, you have to make sure that when the SNP1 or SNP2 is there, it's on the same allele where the CAG expansion is. Only. So if you have that SNP1 or SNP2 on both of the alleles, which is possible, it still wouldn't work because we want to direct it to the only paths. Get that right? So it takes a long time for this. It's been taking 6 to 10 weeks to get this information back, and it goes to a specialized lab in the States. So somebody might come in and we want them to participate and all that stuff, but we have to wait for this to come back, and that's a process that happens. At our place, it's about 55% right now, and that's a sampling kind of thing, and we've had some families that there's been a couple family members and they probably have the same thing. If one person with Huntington's from the family is there and a sibling is there, it's likely going to be the same answer. Could be not. And I explained to Tam before that it is possible that if a parent has this or doesn't have this, it doesn't necessarily mean that the child child could be excluded because it all depends on if SNP1 or SNP2 is on the good allele instead of just the bad. So this is an investigational study. What we're trying to do is to see if we can lower the mutant Huntington protein by only attacking the bad allele. So I call it shooting the messenger. We want to make sure the RNA that's only associated with mutant Huntington's allele is affected. And we're doing these simultaneously, the two studies. So we don't know if somebody comes in, if they're a candidate or not until we have the pre-screening test. We don't know what's, if they fulfill all the criteria, they have to have MRIs. We had one person we didn't know had a blood vessel tangle abnormality in their MRI. We couldn't do it because it's possible that by giving this kind of medication, there could be some problems in the brain. Sometimes these types of medication, any of the ASOs, could cause reduced platelets or bleeding abnormalities. So if somebody has a blood vessel tangle or arterial venous malformation, that's not allowed. That person was excluded. So this is an ongoing investigation. The way this is designed is that people come in and have a single dose of the medication after being screened and having all the blood tests. They have another lumbar puncture a month after, and that's the single dose part. We wait for a block of 12 people in each of the two studies to be finished. We have a safety monitoring board that looks at all the data and says, okay, go ahead and start the multiple dose phase. And then they have monthly injections for 3 months, and then they have another safety LP. We're lucky, and one of the things that we really have to thank both Roche and the Wave people is that people that are participating in these studies can go into what's called an open label extension. So once this study is finished, they have the opportunity to start getting the real stuff as soon as it's available in the label study. Still early days for the Wave people, so we don't have that up and running yet, but we're hoping it'll be dovetailed into the stopping of the first people. So how is this going? We had a bit of a slow start, but that's okay. It should be, the high-level information should be ready about the middle of next year to say, is it safe? So we had this discussion in Vienna at the European Huntington's disease meeting, and I think Ray's touched on it a little bit, and I just want to be very clear. So many people who hear about these studies, and they've heard about some of the animal work from this morning, say, okay, if this stuff works, my symptoms are going to get better. So that's one expectation. Or my Huntington's is going to go away. So that's sort of the even more extreme thing. Versus stopping progression or slowing progression. So I asked the question in front of an audience of 1,000 people or so a couple of weeks ago to the leaders at Wave and at Roche, what does a win mean for you guys? If these trials are successful, what does that mean? So it was very clear that we're not expecting symptom improvement. We don't know what's going to happen, but that's not how the studies are designed. We're not expecting a cure. The studies are being designed, bigger studies, to see if we can slow progression, which doesn't mean we're going to stop progression. So we have to have an expectation of, what's going to happen. We may meet our expectations, but the expectations how these studies are designed are to slow progression, which would be fantastic. I think many people would like to do a lot more than that, but we have to really try to pull down expectations because we don't know how this is going to go. So in the spinal muscular atrophy patients, the young individuals who have the genetic form of Lou Gehrig's disease in the 6 to 12 months, it slowed progression. Okay. And that was considered a win. So we have to put on a slightly different thinking cap about how this works. How often do we need to give this stuff? We don't know. In the spinal muscular atrophy population, they're getting it every 3 months now. It started every month. a year. So that's a very different thing than having monthly injections. We don't know if that's going to be possible with Huntington's. We know that similar technologies are being thought of to actually put this in a virus and inject it in the brain a single time. As I mentioned in one of the other sessions earlier, I'm not sure if I want to be the first in my block to have that done if I was in that situation, because if it doesn't work, if something goes wrong, we can't take it out. So in the spinal muscular atrophy group, again, we're in a situation that they know that this is working for years. Now they're starting to consider this viral-mediated approach. So that was it. I don't know how we're doing for time. We want to leave lots of time open for questions because this has been a hot topic. So I hope this was clear, but let's have some questions, please.
Hi, Dr. Guttman. So I'm Sharon from Ottawa. So I know that lumbar punctures are painful and they're difficult to do. But I was wondering if people with Huntington's who have chorea, does that make it more difficult, or do they have a bit of sedation or some kind of way to rest them or that?
Right. So trying to modify that, I think it is possible for lumbar punctures to be painful, but it's also possible that it's not painful at all. So it depends on the individual, and there are some things, as I've done, I can't remember the exact number, 120 or so in Huntington's patients for these studies in the last year and a half. The older you get, the more difficult it is because people have bony changes in arthritis, and it's harder to get through the bone interface for that. So that puts it a bit of a bigger risk. If you're bigger rather than smaller, it's a bit harder to find the right space, so that makes it a little bit more difficult. But I haven't had problems, and I think Claire, at least comment Claire if you want, but the movements of Huntington's have not been a challenge for us in doing it. Claire, would you agree? Or?
Yeah, that's true. Safely without significant age, without chorea as well.
Right. Now,
We do not use sedation.
we do not use sedation, and the studies don't allow us to use sedation, and it hasn't been a problem. It's interesting, we go to investigators meeting, and some of the European meeting groups don't even want to use a local anesthetic. Like in Germany, they say, we just tell the patient to sit still and we don't even freeze their backs. And we freeze the backs.
Thank you.
So that's now there are some age restrictions on these people that can come in. So if somebody's over what's called a body mass index of 30 in this study, can't get in. And some of the studies, if you're under a certain amount, you can't get in. So that. So one thing I forgot to say is that these are ongoing studies. We have recruitment, but this is a phase 1 study, and people have to live within an hour and a half of where we are. So we get asked from all around the world, can we come into the study? I got an email from somebody from India last week, somebody from New Zealand. Can we move to Canada to be part of this study? That's not a good idea. There's lots of activity that's about to happen. We want, and I'm on the International Oversight Committee of the Enroll study. We have a meeting next week. I've been asked to talk about what are the best study patients. So, the best, these studies are asking a huge amount of the patient and the caregivers. You need to have that support because you're back and forth almost every second week. You have to do all sorts of stuff, MRIs, lumbar punctures, all sorts of things. We're really asking a lot. So we want people that have a stable environment, that live close by, that have good support from their family. And, in Huntington's, there's lots of stuff that's going on all the time in the family and psychiatric things, cognitive things. And we want that to be stable. So it's not for everybody. It's not for the faint-hearted. And we really, really, really appreciate all the patients and the families who put up. And there's some family members in the room here who have spouses or siblings in the study. And it's a big deal. But so the patients are doing a huge amount to bring this science forward, without the expectation that they're going to be helped themselves. And that's amazing, like really amazing.
You mentioned that 12 people went through the initial vulnerability study, I guess, or safety. And how many are going through now? Is it, anyway, and I just want to say, for our family member, yeah, the lumbar puncture wasn't at all difficult, or I don't know.
Thank you. Right, so maybe I didn't make it clear. The study design has blocks of 12 people to get a single dose. We assess if that dose is safe, then they go to a different dose level, another block of 12 is done, and then it goes up. And there's the study design currently is 4 different doses that are being assessed sequentially. And that's called a multiple ascending dose study. It's pretty standard in drug development. So the first group in this STEM2 group has finished that, and now we're into the multiple dose part. We don't have the information. We're blinded to this, but there's a committee that's looked at all the details for every patient and said there are no safety issues going on. You can go to the next level.
Dan, there's a question up here.
Yeah, this is 1 second.
Go ahead.
So I'm Valerie from Ottawa. Linked to the first question, have you had any trouble getting enough participants in this specific trial and in all of the other trials that are going on generally?
So, you know, it's amazing how many people want to do this, and you know, we've had much more than what Wave wanted us to put into this, but you know, we're doing okay, and we're still having recruitment. So, we're doing the other studies. We know that a number of Canadian sites, it hasn't been announced, will be doing the Rose study. I don't see any problems in recruitment, but we're open to people. In the other study, the Rose studies, there's not the travel limitation, so that we will be able to do patients from farther than an hour and a half away. And there will be regional locations for that study, but they haven't been released formally. So, yes, the community's been extremely supportive. We're lucky that we have North York General, who's also in Huntington Center that's not far from us, and there's patients that are being seen there, and we assess them if they want to participate in the study, and that will happen in the other studies as well. We've had patients from Ottawa coming into some other studies, but that they're too far for us for this study.
I just assumed that the punctures were done by an anesthesiologist. I didn't realize you've been a neurologist, so that's well. So my question is a bit different. Why do siblings have different CHG expansions? And does the expansion, does it vary if you have if your gene comes from your father or your mother? Is there a difference?
Right. So for most families, the CAG repeat length or expansion, if you inherit the Huntington's gene from one of your parents, your mother or father, is pretty close to what that parent is. But there is some variation, and there is, so it may be plus or minus 1 or 2. It is possible that there is a little bit of difference in that parent-child transmission. Now, there's a special situation that if there's a male-to-child transmission, there is a potential for expansion that's quite a bit. And I have a family that I saw a young guy who's 28, and his grandmother died prematurely of cancer, but her sister had Huntington's. The dad was 60 or so, and he didn't have any Huntington symptoms, and the 28-year-old boy we diagnosed with Huntington's, and he had a CAG in the order of high 40s. So there has been an expansion from about 41 to high 40s because of that male-to-child transmission from sperm formation. And so within Role, there's actually going to be another study called HD Origins that is asking people in Role to give sperm so we can understand that more. And that's coming up in the next year or so. Blair and I can tell you that in our training as neurologists, it was expected that we learn how to do lumbar punctures. So for treating or diagnosing meningitis, in the past for diagnosing multiple sclerosis, this was part of what we would do when we were on call in certain investigations for different things. Yes, anesthetists are expert at it. So when I was learning the spinal ultrasound, I spent the day in obstetrical anesthesia at one of the hospitals in Toronto because the anesthetists all day long do epidurals, and the technique is very similar, not exactly the same. In some centers, they have chosen to use anesthetist, but I think in Canada, it's fair to say that all sites will likely have the neurologist do this. And I do it as an outpatient in my office. It doesn't have to be in a hospital.
So I have a question about a little bit about the comparison of the Roche and the Wave. So we heard yesterday about the Roche study and the advantage that it is applicable to all patients who don't have to go through the SNP 1 and SNP 2. I'm wondering if the Wave study might have some advantage. I mean, obviously because it is a little specific, but also might that mean that dosages could be much higher in the Wave study? Might we be looking at something that's actually gene silencing as opposed to lowering?
Good question. So certainly, if you compare the two studies, based on the initial phase 1 B2A results, we know that in the dose that's been chosen for the Roche study, there was a 40 to 60% reduction in the mutant Huntington's. We don't know if that's the right number. Do you need less? Do you need more? If you leave the normal allele, the wild type, totally intact, could you knock it down further to get more of a complete response? I don't think that's been well, we don't really know the answer to that. We haven't figured that one out. We don't know what the pharmacokinetics are, how much of a reduction it's going to be. With the way that the ASO is being formulated with the stereopure aspect, there may be a higher potency because you use less molecules. That's a possibility. These things will be sorted out after we look at the results in phase 1B before we get to the phase 3.
So they may be part of the exploration of some of those questions.
Yeah, so I would add that I think these are to your question on, sorry, and I also not used every single microphone. That was World 1. Your question on kind of potency and dosing, I think it's important to remember these are different compounds, very different compounds, and comparisons are inherently tricky in comparing drugs, right? You actually have to design a very, very carefully design a study to answer that question, and that's not even close to where we are at this point. Maybe one day, much further down the road, I think there's a bunch of safety, so it's making those comparisons statistically, it's almost impossible at this point.
It's something we try to avoid so early.
And ultimately, you would need a head-to-head study to really say, is one drug different than the other? And that's way down the road if it ever happens.
Just a question, you mentioned that the mutant protein is what builds up over time and causes damage to various parts of the brain. But if you were successful in really blocking this protein to a substantial amount, could the brain even recover if it was not being subjected to this buildup of protein?
So that's an excellent question, and we don't know what the turnaround of protein in human brain is. If you block it, can the brain clear that? And a cell that is sick and not functioning well turn back into a cell that's functioning well. That is a possibility. We don't know that. So it'd be wonderful if that happened, and there may be symptomatic improvement if that happens, but we don't want to overpromise is the bottom line. In some animal models, it's been shown if you block this, you can clear out some of the protein deposits. So,
Because people recover from strokes too, or get damage to the brain, and the brain learns the new pathways or whatever, I guess, so people can recover.
and there's a huge area of interest called, with the brain compensating for certain things and learning new pathways and doing different things. So it's possible that that compensation can be more effective if we can have that stuff. But
Yeah, I just wanted to follow up on the question, sort of Huntington silencing using ISOs. And, I can't speak directly to this, but people that know a lot more than me have sort of given me some information about this, and I'd like to pass on. It may not be possible using ASOs based on their mechanism of action to ever get Huntington silencing or even silencing. So Ionis has extensive experience with ASOs and a variety of different approaches. And almost in every case, there's a level that you cannot push the system below. So there's an endogenous, in the case of the ASOs that we're talking about, an RNase H1 based mechanism, you can't overwhelm, you can't get 100%. Probably the maximal knockdown that you can get is around 20%, to the level of 20% normal. That's what I've been told. I don't know if that can be overcome, but my understanding is that there's a limit to the lowest, the amount of lowering you can get. And Huntington silencing is probably not feasible, certainly not with doses that can be given safely and efficiently. So, I think probably that as a goal would not be likely achievable, is my understanding.
that's an excellent point. And talking to Ray about this, Ray Truitt, we're not even sure if you need 40 or 60% reduction. It's possible that reducing it by 20 or 30% would be enough to have clinical improvement in patients, which would be good. So this is still all unknown right now.
Yeah, I have a question about the other 33% of patients that there are no drugs targeting their genes right now. And I kind of heard hints that, that you're working on. So basically, I know you can't give me a timeline, but let's say if the drug is safe, and let's say for SNP1 and SNP2, and let's say that it works, is that you're going to have it fast?
Take that one.
So I think there's certainly some lessons learned, some commonalities we can apply between, say, SNP1 and SNP2 and, say, SNP3. But there's a lot of research we need to do to make sure, to understand the prevalence of that SNP3, to make sure that we're not just finding a SNP that's also in just exactly the same people, right? So we're not just targeting a drug that's targeted at, well, we're going to add SNP2, because that's not really going to help those 33%. So then that's not a great answer to your question. We are working as quickly as possible, though, is what it comes down to.
You do have efforts to basically tackle that other 30%.
Yes,
Absolutely.
we want to get we want to try to get find steps. There is, certainly we went for the two that had the biggest return right away, that reached the most people with the first two. So there's some kind of diminishing return, but we're committed to kind of keep going and finding additional steps to reach those.
Some other questions? Somebody else?
I should have went to my run.
Good afternoon. I'm just curious with your ASO research, are you far enough in the development that you find that it's reversible?
I'm sorry, it is?
Is it reversible? Have you gone far enough to study to know that if you stop the drug at the level of
Right. So as Blair identified in the talk that he gave, that was excellent, this comes mostly from preclinical work, and so in animal models. So we don't have that information right now because the patient numbers are so small. We're just finished that first group. So I certainly haven't seen the data. I'm blinded until the end. So it's important that the investigators don't see information throughout the study because it might bias you. But we'll have that information because people will have their final dose, and then there's a spinal tap after that, and we'll get the concentration in the spinal fluid with also the mutant Huntington's concentration and be able to look at that specifically. So in a similar way that we had a presentation from the phase 1b/2a study with Ionis, we'll be able to get that. There's another question.
My question is just about, so I know that these studies are going to happen at other sites in different countries, but in Canada, for example, how diverse are the populations that are within the study? And is there a way, I mean, does it hamper to have them have ethnically diverse people in these clinical trials, or how does that work? Just want to know a little bit more.
So traditionally in a phase 1 type of study, we're asking a big question.
Yeah.
Is it safe? And we don't have a recruitment strategy that includes ethnicity, variation, and things like that. We would like to have male-female variation, and that there's not targeted recruitment specifically. However, in the phase 3 huge studies, we heard about the 660 patients. I think in those studies, it's possible to try and say we need to capture more ethnicity, and that can be done in a number of ways, including going to 15 countries that you'll capture different ethnicities in different countries. I've been involved in studies that specifically want, if they're funded by a National Institute of Health, a certain percentage, usually 10% of people that are non-Caucasian, and certainly they look for a good male-female balance. So in this kind of early phase study, we don't have a recruitment strategy that looks at that, but I think in the phase 3 studies, that will be a question to be answered.
So would it be open to people, that's my question, so like when you're recruiting right now, would it still be open to people that are not Caucasian?
Absolutely. Absolutely.
It's on the same level as a reported marker. Even though it's not focused, is a reported marker of.
I'm not sure.
You record the
Oh, yeah,
ethnicity of the person.
absolutely. So as part of the basic demographics, we record ethnicity and gender as well.
I have a two-part question. It's specific to a quick study. My question is like of dosage and potency.
Louder.
Is that better? There we go. Okay. My question has two parts about dosage and potency. Is there any concern about any dosage activating response in the CSF? And if so, like from a pharmacokinetic perspective, is there like any concern about an response kind of altering the integrity of the exo's ability to target the SNP?
Right. So in this phase 1 study, probably didn't get to this, but there are some non-specific inflammatory indicators. So we know that if there's inflammation in the central nervous system, we could get elevated white cell count and elevated protein in the spinal fluid, and that's being looked at longitudinally with each lumbar puncture. I'm not aware. I think there are some markers, I forget, of peripheral immunological things, but I'm not aware of having antibodies against the ASO that we're looking at in this phase 1 study. So I think that's probably phase 3 material.
Do we know how long the drug stays in the body? Like
This is a first in human study. So we don't know right now. We have projections based on animal models, and that was similar in the Ionis experience. So we don't know, and that's one of the things that's being measured. So when somebody comes in and has a lumbar puncture a month later, they're having it measured so we can see if it's lasted that month. When they're having monthly injections, does it accumulate in the system or not? And we do blood tests as well after the injection into the spinal fluid. Is it getting into blood? And we're measuring those blood samples quite a bit in the first number hours after the injection. So these things are part of what we're looking at. But when I was there with and Blair had the same experience, the first patient in the world, the first patient in the study, doing these injections, you don't know these things as well. And I think it says a lot that in the Iona study, Blair was the first in the world, and we were lucky to be the first in the world for this study. So Canada is very much leading the way in these areas.
If I understood correctly, if I understood correctly, you mentioned the SMA illness. Is that a childhood genetic illness that's being treated with an ASO?
Right. So Ionis, in their first drug was actually in a retinal condition, but in the real excitement people got with this childhood form of Lou Gehrig's disease called spinal muscular atrophy, and that is a genetic condition, and they targeted their ASO against the genetic defect. And in their study, they actually stopped the study, the phase 3 study, earlier than expected because they had what's called an interim analysis. And the interim analysis said the people in the placebo are doing much worse than the people in the active treatment. They shut down the study and it led to a rapid approval of the medication before the timelines that they were expecting. So in our dreamable dreams, this is what would happen with HD, and the drug was approved and is being given. Ray mentioned that there is being a big financial price tag. We don't have a price in Canada yet on that drug. It is being administered. I have my neighbor's a pediatric neurologist. Children are giving it there. They're giving it in other places. And from what I understood, it was $750,000 the first year, and then afterwards $400,000 a year. Why the first year is more, I don't know. There might be more doses involved. But that's a huge price tag. In some way, it's not unusual for an American price tag to be here and a Canadian price tag to be here. So we don't know what the Canadian price of that is.
That was actually my question on price, like how is it being paid for now for people who are getting the ASO for SMA? And if that might be reflective if one of these ASO studies were.
Yeah. So this is sort of all speculation. In Canada, it hasn't been formally approved for general use yet. It's still under investigation from what I understand of Canada. So they're not selling it yet, so we don't know what the price tag is. At least that's my understanding. And there's often a difference in time frame for when the US approves and Canada sometimes works first, sometimes they're first. But we have no idea what this price is going to be. It's not going to be $10, that's for sure.
Nurse in the ASO for SMA has been approved by Health Canada, and actually just very recently, British Columbia, the medical services time, British Columbia has approved the coverage. So British Columbia currently is approved and covered by the medical services plan therapy.
So I wasn't aware of that because these pediatric neurologists I keep asking her. I asked her last week. She's part of my running group. And so, anyway, so it sounds like BC is further ahead, which is very interesting because BC is often the last place in the country for things to get covered.
This is an area where patient advocacy makes a huge difference. Saying who are patient advocates in the room.
Meaning everybody here.
Not to really start.
So I think we're
time for one more.
Hello. So I'm from a family. I've got siblings and a father. So this is the $1 million question that all of us here want to know. The stars line up. We won the $100 million lottery. We're going into phase 3. We're halfway through, and they go, "Hallelujah! This is happening. It's all working. So we're we're doing exactly what this study did before, and we're opening it up. Now, do they open it up to the public? Is it a, boom, let's go, anyone who's been tested, come on up, we're going to start putting things in your spine? Or is it a much more controlled? Is it like, okay, well, in a situation such as this, we're going to give it to 1,000 people while we continue to do studies? Like, how does that actually work?
Excellent question. And this is what's going on in the spinal muscular atrophy world. So they tested it in a certain population, and from what I understand, it was approved for the use in childhood SMA. And so in the States, people that have that, kids that have that, can have a prescription for it, and then it gets into, is their insurance company going to pay? Is the family going to pay? Neurologists are administering this on a regular basis now. The next question was, okay, there's a different twist to the SMA that you get later in life, but it's the same gene. Could these later onset or adult onset people get the same stuff? And the insurance companies are saying no, it wasn't tested, it's not approved for that. So there's something called, approved indications, not approved indications. So what relevance does that have? Well, in our world in Huntington's, yes, we want to find out if it works in the patients that we're testing it, and those are mostly early to moderate patients within a certain time range. What happens in the juvenile group? Can we use it for them? What happens in the over 65 group? But even more important, what happens to the people who are pre-symptomatic gene carriers that don't have any symptoms at all? Can we use it with those individuals? And we don't know how that's going to go because, I think what's going to happen is that we're going to need other studies to prove that. And, we have in the other research area that I work in Parkinson's, medications that's used to treat Parkinson's symptoms gets approved, but people were speculating that could slow progression or modify disease, and it wasn't approved for that indication, and the insurance companies wouldn't pay for that, including the government bodies. So I think that if there's something big like pre-symptomatic, potentially stopping the disease from coming about, there need specific studies to support that. So once it's approved, you can prescribe it. The next question is who's going to pay for it, and will insurance companies or government agencies pay for it? That's another step.